Okay, so here you are for Cleft Palate 2. Um, there, the way we typically treat cleft palate, it's not just an SLP, right? It's not just one of us in there. It requires a huge team. So you need a plastic surgeon, somebody that's actually doing the surgery. You'll have an SLP to help the child, well, to assess different speech problems, and also, depending on the age, um, offer some therapy. There's an orthodontist to deal with any tooth problems that will come up, especially with the cleft lip and alveolar involvement. There's orthodontical problems that are definitely going to come up. I mean, you're cutting right through where a tooth should be sometimes. So sometimes a tooth just doesn't grow in. In the same way, you may have a pediatric dentist. So I should say these ones that are bolded, they're always in the team. And then the people that aren't bolded may be part of the team. So pediatric dentist, geneticist, probably not super typical. Psychologist, possibly. An audiologist. It's another one for the few of you who are going into audiology in this class. This is something that you can be a part of as well. A pediatrician might be part of it. Nurses, nurse should be bolded too. There's always nurses as part of the team. An oral maxillofacial surgeon. The reason that's not bolded is sometimes it's just a plastic surgeon and not somebody who specializes in that kind of repair. But if you can get somebody that specializes in that kind of repair, that would be better. And then also an otolaryngologist. This is something I'm not going to go over a ton, but there are documents for parameters of care. So if you are really interested in this and you would like to eventually go into this when you are an SLP, take a look at this. And then there's some external resources at the end of the slideshow that you might want to take a look at too. So how do we diagnose this? Do we just wait until the child is born and then say, like, wow, look at that, they have cleft lip, we probably should have fixed that earlier? Well, no, we definitely don't do that. Ultrasound can help us identify this. In fact, ultrasound is very effective for identifying cleft lip. The reason for that is, we're using sound to bounce off of surfaces, and ultrasound can go through the stomach and through the musculature of the stomach, and then get to where the baby actually is, and then return an image from bouncing off of the surface of the baby, essentially. But it's difficult to go deeper. So we can get a picture of what the baby looks like. We can estimate the depth there, so we can shoot the sound in to the stomach and get to where the baby is and get a pretty good picture with the sound returning. And so then we can see, dips in the lip or, cuts coming up. So we can kind of see what cleft lip is going to look like. But if it's just cleft palate, that's much harder. You've got a head in the way, and you don't exactly know where you're putting the scope or exactly how to calibrate the scope. So it's much easier to get a view of the lip. We're also getting better as tools and diagnostic methods increase. People are getting better at being able to identify cleft lip and cleft palate as well. But again, cleft lip is much more easily diagnosed. What's really cool is when you know ahead of time, you can kind of schedule the surgeries before the birth actually happens. Early intervention, we've talked about early intervention before. We know that early intervention with speech problems is key, but early intervention here is key too. So we like to get these surgeries done as early as possible. You'll see very soon that you can't do it immediately. There's some things that we have to wait for, but you can do them quickly. So you can even schedule them as soon as you know that this is a problem. It also gives the parents a time to come to terms with the diagnosis. It's not a terrible diagnosis, but of course, it might seem bad to parents who are expecting that nothing's going to go wrong in the process. But again, I mean, the surgical teams, especially in most countries, pretty much everything except for the most developing countries are really good at their job. So it's not a great diagnosis, but it's not a terrible diagnosis either. Okay, so feeding is going to be a challenge, but let's do this out of sync. Usually I talk about feeding first, but let's talk about the surgical repairs first. So we'll have chyloplasty is just repairing cleft lip and the alveolar ridge as well. Usually you can do this around 3 months. So that's, pretty quick after birth. The reason why we want to wait 3 months is because you do have to use anesthesia, and you have to make sure that, the baby can handle the anesthesia. So they have to be the sufficient weight. They have to be, strong otherwise, and then you can give them the anesthesia and give them the surgery. You want to do it as quickly as possible because from a few of the lectures that you've had from me and from 2 of our guest speakers that children are going to start babbling almost immediately. There's some sort of vocal play, there's some sort of use of the vocal apparatus and the articulators almost immediately. So the quicker that we can get this fixed and back to normal, the better, because that allows them to get used to their new articulators. So without this cut here, and that'll allow them to get used to that and then say their speech sounds correctly. And also we want it to look good. And the earlier you can do it, when the baby skin is still really good at repairing all sorts of surgical procedures, the better. So you might have a minimum of scarring, or possibly even none. I should say, there's always going to be some, but not easily noticeable is what I should say. Then we've also got palatoplasty, which is a little bit more involved because it's the palate, it's not just the lip. And this is it's a bigger procedure, so it's typically going to be about 9 months. With this, you've really got like a 3-month window because you want to do it before 1 year. There's a lot of vocal play that happens within a year. We know that. We've learned that. There's a lot that happens developmentally in a year. I mean, even waiting 9 months, we have to for the safety of the child, but if we could do it earlier is better. And so the team that's looking after any of these kids that have this problem are going to be assessing. They're going to be looking at weight and strength, and if they can do it a little early because they're ready, then they will, to help facilitate correct development of speech. All right, so now we can jump back to feeding. So you can see that with cleft lip, you've got 3 months where you're living with cleft lip and out with possibly cleft alveolar ridge as well. With cleft palate, you've got 9 months, somewhere between 9 and 12 months, with the problem still in play. So that's quite a lot of feeding that's going to have to go in. So there's 2 different types. There's a lot of different types of feeder bottles, but these are the 2 main ones. So you've got this one here, this Medela feeder, and you can see that it's kind of got like a syringe-like back on it. And essentially what this is you as the person who's feeding the child, you're basically just gonna, like, think of it like a super soaker, right? So you're just gonna like shoot the milk in, and they're gonna have to drink when you're shooting milk at them. It works, but it is feeder directed, like I say here. The feeder's directing it. So if the baby doesn't want to eat right then or drink right then, and you're shooting milk into its mouth, it's probably just going to let it all fall, right back out at you because it doesn't want it right then. And if it's looking for some and you're not thinking that it is, then it can't drink when it wants to because it's feeder directed. Now there is this one called Dr. Brown's specialty feeder, which is not feeder dependent. Like, you are not necessarily doing it. So what happens is there's this valve right here. So you fill this up with milk just as you would any other bottle. And you've got a valve right here, but the valve only goes one way. So you turn the bottle upside down, milk comes into the nipple portion, but you turn it back up and it stays in there because this valve only travels one way. And there's a whole bunch of little holes where they're actually like slashes cut into the nipple of this bottle, and they stay closed until the baby pushes down on it. And when you push on it, then the milk can flow out. So this actually allows them to feed when they want to. So it's a lot easier for the person that's feeding, and it seems like the children enjoy it more because they can eat kind of at their leisure, and you don't have to guess what's good for them. So this is something, if you have, or you know someone with a child with cleft palate or cleft lip, it's usually more useful for cleft palate, but I suppose you can use it for both. This is a good thing to go for. I believe that link takes you right to it takes it to a video. Never mind. No, I did link it to. Okay, I did link it to the actual website where you can buy these. And then when you're an SLP, or even some of you are thinking about doing the SLPA program, this could be something to recommend if you're working with a family that's dealing with cleft palate. Okay, so we talked about those. Okay, so we kind of touched on this already, but we'll talk about it again. So, what sounds do you think somebody with an infant, I guess, but somebody with cleft palate might acquire earliest? Well, is a really prominent one, right? It's really easy. Ma is perfect. It's going to be pronounced correctly whether they have cleft palate or not. So ma is definitely going to be one of the ones that you see. Na ga no, that's too far forward. I'm thinking ka and stuff like that. All that's behind where the velum is, that can come out. Or nasals. So nasals or sounds, consonants that are produced pre-velum, before you get to the velum, any of those are going to be sounds that you'd expect someone with cleft palate to be able to make perfectly. Now, there's going to be some that they don't make. Am I jumping ahead of myself? Yes. So there's some that they don't make, and those are, we've talked about it, ba, pa, ta. You heard that sh was really hard in for that one girl in that video. Sh was a hard one to make. It's typical. Is occasionally also hard to make. What you do see is compensatory articulation errors. You might have caught this on one of those in that video as well. She was supposed to say ba 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 ba, and she just went for ma 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 ma. It didn't even sound like an incorrect ba. She just said ma. So this is the compensatory articulation error. She's using m instead of b, because when she tries to say buh, it just doesn't come out right. It doesn't sound good. So she's then changed it to a sound that she knows that she can actually make. So all of her buhs are muhs. And this is what you expect from someone with cleft palate. Now, cleft lip doesn't usually affect speech development. Yeah, you've got some sounds like buh and puh that might be harder to make because you can't hold the high pressure in puh, because you've got this cut right here. But you can do a little bit with it. The lips are a little bit more flexible than the palate is. You can move them around. Of course, bilateral cleft lip is going to be harder to deal with than unilateral cleft lip. So you'd expect there to be slightly more problems with someone with bilateral cleft lip than with unilateral. With unilateral, usually there are hardly any. With bilateral, there aren't many either. Oh, yeah, I did want to touch on that too. So after cleft palate, there's not really a good after cleft palate surgery, I should say. There's not a good there's no normal speed that children are going to develop speech. Some do it really quickly. You can have them, come out of the surgery and they're really good at still, engaging in vocal play, trying out the new sounds they can make. If the parents working with them, if the SLP's working with them to, try to replicate the sounds that they're making. Some do it almost immediately. And with others, they haven't had this structure there before, in the middle of their mouth, right on the palate. They haven't had that structure there, so it's interesting, it's new, it's confusing, and it can take some time to get used to it and try to be able to make these new speech sounds that they might have had trouble making, or possibly even differentiating from a couple because they can't make them. So there might be 2 or 3 speech sounds that they think are pretty much the same because they only hear them from other people, but they can't really make them. So it's also hard for them to occasionally get out of the pattern that they've learned. So even if they know, now I can say buh correctly instead of muh, but they've really gotten into using muh in place of buh, sometimes it's hard to break that habit. And of course, the longer you go before getting the palatoplasty, the worse that behavior is going to be. So in the United States and in England and Europe, Canada, Japan, all sorts of anywhere that's you would consider like a first world whatever country, these surgeries are done quickly. So we give them the best chance possible. In other countries, though, kids can be a little bit older before they are able to get the surgeries to correct cleft palate, and so then they might be stuck. They might, it might take a lot more work, or they might not ever get out of it, of using muh in place of buh, because it's now not just something they've had to do because of a physical disability. They've had to do it because of that's just their pattern of behavior that they've learned. So the earlier the better. Okay, so we talked about velopharyngeal function. Yeah, this is all stuff we've talked about. We talked about velopharyngeal insufficiency. There's TBI is something else. Cerebral palsy. These are all other causes of VPI. Here we go. Okay, this is what we want to talk about. So you'll be able to notice hypernasality, which means extra air coming out of the nasal cavity is essentially what it is. You'll have nasal type resonances in all speech sounds. So if you've had speech science or if you're about to take it, when we talk about nasals and the nasal resonances that you can detect in nasals, you would expect to see those in a spectrogram of these people's speech. So if they have VPI, submucosal cleft palate, anything like that, you'd expect to see nasal resonances where you shouldn't in non-nasal sounds. You can also feel air coming out of the nasal passages, or you could do that test where you put a small mirror under the nose and it'll fog up because there's air coming out of the nasal passages. And then again, some weak consonants, not necessarily all of them, but some of them, and that's because air is leaking out through the nasal cavity. Sorry, that was just a random yawn in the middle of talking. Sorry about that. There are a good percentage of people who end up with VPI after having cleft palate repaired. Why would that be? Well, I'm sure that a lot of you can guess the answer to that. Sometimes you can have cleft palate and the muscles develop and it's okay. It's just the bones haven't come together. But some people who have cleft palate, though, that musculature had never developed because of something that happened during the developmental process. So 10 to 35% of children would have had submucosal cleft palate if they didn't have cleft palate already, because that musculature didn't grow. And again, there's other people that can have submucosal cleft palate without cleft palate. So just like you can have cleft lip without cleft palate, you can also have these in different orders as well. So what's going on with this 10 to 35% of children who have cleft palate but then have it repaired is that they've got submucosal cleft palate as well. Like we talked about, you can do some things for this. You can use a speech bulb. That can help. There is a surgery for it as well, and what this can do is it can help elongate the velum, or it can make the velar opening a lot smaller. So you can just do a surgical procedure to close the velum a little bit and then allow the pharyngeal constriction to be what closes it, just like using a speech bulb. These don't usually happen right away. In fact, I think it happens around school age. Do I have that written on here? Yeah, between 4 and 6. So around school age is when these surgeries are going to happen. A speech bulb can usually be fit much faster than preparing for surgery. It's also much less invasive. So if the child is okay wearing a speech bulb, that's totally acceptable. It kind of depends on the severity of the problem. You know, how bad is the opening? You saw that there were different types of VPI. There was very mild to moderate to severe, and if it's a really mild type, why go through a surgery? Just wear a small speech bulb. If it's severe to the point of it might not even work with a speech bulb, the surgery could be the option. Okay, so we talked about compensatory articulation. Yeah. Okay, so some of our speech assessments, we want to look for, which I'm sure that this is not going to surprise you. You want to look for hypernasality. So you want to look for extra air coming through the nasal passage, extra resonance in the nasal area. You'll have a different sound to it. It'll sound more nasal. We listened to someone, it was a kid talking with a very nasal voice in our lecture about articulatory versus phonological disorders. It was the second kid with an articulatory disorder. He had high nasality of speech. Also, a lot of the children that we just listened to in the video from the last video, there was a lot of hypernasality in that speech as well. Sometimes you can actually hear air leaking out of the nose while talking is going on as well. Just kind of like a hiss of air every once in a while. And you can also listen for voice and fluency problems, and these will cue you for what you might be looking for if you use instruments. So you want to do your typical evaluation. Maybe use a Goldman-Fristow test to listen for problems with all of these different speech sounds in all of the possible placements. Once you have identified the sounds that might be a problem, you kind of know what you're looking for. You think you might be looking for VPI. You think it might be mild or moderate. So what you can do is you can look at nasometry, which is this right here. This is actually measuring how much airflow is coming out of the nose. Or you can just scope the nose. So you can throw this scope up in the nose, up through the nasal passages, and then down into the pharynx. And you can look at what's going on in the velum right above it. That's the same technique that we saw in the last video when we were looking at different, all those people's different mouth, velar port areas. Sorry for not warning you about that last one. I forgot that it was gross. Okay, so essentially what you want to do when you're working with a client that has had cleft palate or just come off of surgery for one or is doing surgery for VPI, you want to, there's a few different things. You want to add the consonants. So first you want to teach them how to make b and p and different things like that. And then what you want to do is you want to try to reduce compensatory articulation. So when they're saying m and they should be saying b, you want to guide them back to b. And that's, it sounds like not a whole lot, but it can be difficult, like we talked about. So it could be helpful to start with just one, or depending on your style, depending on the client, you might try to teach multiple different consonants at a time and then start pulling away from compensatory articulations. And of course you want to increase the expressive vocabulary as well. All right, so this is, I think, where we're going to end here. Yeah. So you know about the different approaches. We've got phonetic approaches and linguistic approaches. One is we want to focus on motor movements. That's the phonetic approach. So you want to have them watch you. You want to tell them to feel the pressure when you say the b. You want to kind of draw their attention to all of these physical properties and how they're working, and then produce the sound that way. You can also try to teach different rules first. So you can try to work with them and try to hear the difference between mud and bud and things like that, and get ready to try to say these things that way. So instead of focusing just on the motor, you can try to focus on these speech rules and then see if they follow along that way as well. And that's where we're going to stop. There's roles for SLPs and AUDs. It's just short. Here's a little bit on genetic syndromes that involve clefting, which you can read on your own. And then here's one thing I want to leave you with, are resources. So you won't be an SLP for a little while, so these aren't something that I think you're going to necessarily hang on to for when you do have clients, although if you want to, that's cool. If you want to download this and save it, or just know where it is on Canvas, that's great. but I'm sure you'll have other classes where you get more information on this as well. However, for you or for people family members, friends who might actually need these resources, here they are. Remember, also there was the Dr. Brown's bottle a few slides back, so definitely take a look at that as well. Okay, that's the end of this video. The next one is going to be about fluency disorders, and then that's actually all you're going to have for the week. So it's a slightly shorter week. All right. I'll see you soon.